Thank you very, very much. Thank you for that introduction, and it's delighted to be here. It's a real pleasure. It's actually the last couple of days, though, it's kind of difficult to imagine that you're actually in Ireland. Blue skies, sun, pretty extraordinary. So it must be the luck of Limerick people. I also want to say that it's been a pleasure to be back here at the university because it was mentioned that we have a medical school, and when we were contemplating doing a medical school some years ago, one of the places that we visited was UL. And I came here with the person who eventually became the dean of our medical school to learn from some of the things that were happening here. And there were Paul here, and others were very, very liberal in sharing their whole curriculum with us, etc. So we have obviously opened up a medical school, and it has been fantastically successful. But a little gem of that success is also due to the relationship that we have here with UL. So I thank you, Paul, again for all of the help on that. Let me just say just a couple of moments. North Well Health is what was, up until a couple of weeks ago, North Shore LIJ Health System. We're the largest health system in New York. The numbers have actually increased in the last month or two. We have all of the delivery system from the acute to the ambulatory. And home care, we have research. We've got a medical school. We opened up a nursing school just about 4 weeks ago. We have an insurance company. We do extensive amount of work in the community health arena. We have right now about 61,000 employees. We are the largest private employer in New York. Our catchment area that we serve is about 7-8 million people, and we're continuing to expand and grow. And I have been, as was just mentioned in the introduction, I have been in many parts of the health system over the years. Obviously, today I'm on the provider delivery side. I did spend a lot of time, it was mentioned, in government. I will reflect on that a little bit later because I'll make some comments, but it's important to remember that I did spend a lot of time in government, so I understand the government side of the world, the good and the bad. I spent quite a number of years in academia as a professor at Fordham University. And I also worked on the insurance side of the business in New York as a senior executive with one of the big insurance companies in New York. So I've been on all sides of the healthcare arena, basically. I've also been a patient multiple times. Happens when you've played hurling in the old days. So I have been a patient, and I will reflect on that in a moment because that's very, very important. That's probably the more important role that I've ever played, was spending a few days as a patient. Because when you do that, you get to understand about healthcare better than you'll ever understand reading about it or actually being on the provider side alone. So I understand that the US system is different than the Irish system. None of the systems work as well as anybody would like. The United States system has got lots of issues. But there is no thing as one United States system of healthcare delivery. It depends on where you're located. It depends on the area you're in. It depends on the organization you work for, because there's lots of diversity in the delivery organization of healthcare in the United States. And I'm somewhat familiar with the Irish system. I did serve on John Higgins' committee that put together the report on groupings of the hospitals. And I will come back and reflect on that in a few moments. It is true, however, to acknowledge, as everybody here does, that we're going through a major, major transformation in healthcare, both in the US and here and in other countries. Almost every country is trying to deal with the issues of success in many ways, because as you mentioned, we are dealing today with the results of lots of success of what healthcare has delivered over the many decades. People are living longer, which brings upon itself serious issues now of comorbidities in the later parts of life. And people are living 100 years longer than they did 100 years ago, as was mentioned. So it's important to reflect on the fact that we've had enormous success or in the technologies, the devices, the drugs, the delivery systems, to get us to the point where we're in a much better situation today than we were before. Despite that, there is extraordinary opportunity for improvement, and both systems are going through transformation, major transformation. In fact, I like the title of the conference, Revolution, because in many ways, to some extent, there is a revolution in healthcare delivery and financing and quality, etc., going on all over the place. And we can obviously get into some of that in the panel discussion. But from my perspective, it's a fabulous place to be. It's wonderful to be in healthcare these days. It's exciting, especially exciting for people who want to innovate, who want to do things differently, who want to break some rules and bend some rules. It's wonderful for people who are not hostage to precedent, who are not tied to tradition, who want to say, just because people tell me it can't be changed doesn't mean we can't change it. It's a wonderful place to be for people who want new ideas, who embrace new ideas, who take on and make decisions, and unpopular decisions, even when the consequences are unpredictable. That in many ways is what leadership is all about. It's about embracing change and making things better going forward and taking a long view. We're constrained often, especially if you're in a government control system, you're often constrained in having to look at a longer-term view of the world. And I think that that's obviously a disadvantage. And what people obviously today we're talking about health, we're talking about medical care, we're talking about cost issues, we're talking about the advancement of new knowledge, and we're talking about innovation in education. So let me make a couple of general comments. One is that, and I will discuss, my perspective will be from the delivery side. Other people will talk about the specifics of research and other things, but I'll talk primarily about the perspective from the delivery side. And I was involved with the discussion on the committee with John Higgins, as I mentioned before, about creating in this country hospital groupings on the way to eventually creating hospital trusts. And I think that's a move in the right direction. But I will come back to it. But as you look at what we need to do both in the US and here in looking at how it is we change the way we deliver healthcare so that the product at the end of the day is a better product than the product we deliver at the moment. There are a couple of things that we've got to keep in mind. One is that we have to have an extraordinary focus on the customer and the patient. What I mean by that is, and that sounds like kind of simple, but it is not that simple because that's not the way we often look at the issues. We look at issues most of the time from the inside out rather than from the outside in. What's important in any reform effort is what the patient and the customer requires, needs, demands, and wants. Not what professionals want to give. Not what bureaucracies want to provide. Not what constituency associations want to deliver. When you spend your time looking at and dealing with a lot of the issues that are complaints on both sides of the Atlantic about wait times, about access, about convenience, these are issues that if they're looked at from the perspective of the customer, you have a whole different view. What does the customer want? And I use the word customer because there are patients, and everybody is a potential patient, so there are others that are wondering about what will happen when I become potentially a patient. What are they looking for? Access, convenience, fabulous service, great quality outcomes. That's what they're looking for. Increasingly more and more, especially given the uniqueness of today's patient and customer. And if you look out over the next 10 years and you're looking at the millennial population, the Gen X population, whatever you call them, and the use of technology, and the way we access information today on all other areas of business, just imagine what those technologies can do in the area of healthcare about how it is you should be able to acknowledge and what information you can actually find out through your technologies that we don't necessarily use in healthcare as we automatically use in other industries. So it has to be unbelievably focused on what the customer wants, because we are in business to satisfy the needs of the customer, not the other way around. The second point is that the discussion has to be more and more about the provision and it has to be about health and not just the provision of medical care. Medical care is a component of health. They're not the same. We spend so much of our time just on the medical, yet the influences that affect health, about 70% of them, don't have an awful lot to do with the provision of medical care. You have to go upstream. It's lifestyle, it's behavior, it's social circumstance, which drives an extensive amount of issues that we deal with medically later on. So the big question going forward, in my view, when we look at healthcare, is how we influence lifestyle and behavior. Not just only how we fix the issues of medical care financing and medical care delivery, because they're not the same. And the third item has to be one about education. And being in a university, it's very, very important to raise. And I've spent a lot of time on university settings. But if we want a different product to be delivered a decade from now, we have got to figure out how we educate differently beginning today. You can't deliver a different product in the future by people who have been educated in a world that is different than the world that we're going into. So our education with regard to physician education, that's why in our medical school is pretty different and unique, quite different than most other medical schools in the United States in how we do things. But it's the same when you talk about nursing education, when you talk about education for administrative staff. And it's important that for anything to work at the end of the day, all of those have to work in tandem. There can't be any silos. It's all together. But if you don't rethink the educational functions today and plan for the way you have got to educate going forward to deliver a different product in the long run, you're not going to be successful. I've always felt that the huge gap in getting delivery system change is trying to get people to do things differently, completely differently from the way they were educated. You want doctors to work in teams when they're trained in silos. You want people to work in an interdisciplinary way when they're trained in a separatist way, for the most part. There are exceptions, of course, but for the most part. So the whole education piece is important. And one other part to this is that you've got to be thinking about how to bring the best talent that you could possibly find into the healthcare arena and bring people in from other industries. And don't confine yourself only to bringing people in only from the healthcare arena. You bring them in from outside. And it's everybody working together. I was reading a report on one of the Irish magazines I got recently about a small debate that's going on. And I don't know all of the details of this debate, but I was a little bit struck by the fact that there's a big debate going on as to whether we need PAs or not. It would be hard for us in the US to figure out how you'd actually operate a place efficiently if you didn't have PAs. If there's a discussion going on about the necessity of even thinking about it. So let me raise another issue that I think is very, very, very important, given my limited experience here. But I think from everybody I talked to, and everybody I've been discussing things with over the last couple of years, it is very, very fundamental. And I know it's not popular, and I know some people don't like it at all, but I quite frankly don't care. You have to lose the grip and remove the grip of central control and allow local innovation and regional innovation. Unfortunately, in the US at the moment, there is a tendency also in the US at the moment to have Washington try to tell you more and more about how to do things, which in my view over time will be a fundamental disaster. You cannot centrally control from a far distance what you actually have to do innovatively locally. It can't be done. It won't work. Even in our health system, we're pretty large, but we're not a country. It is very, very hard to totally manipulate what can be done in each of the individual hospitals by creating the criteria centrally. If I tried to do that, I didn't allow the innovation to occur in the local delivery sites, you'd never move forward. Just can't do it. This is a cultural issue, of course. It's different philosophy than often is maintained in some places, but I do think it is something that has to be seriously considered. The other thing that point I want to make is the issue around creating an integrated system. And this is where I have an awful hard time understanding some of the debate that's going on here. And again, please forgive me when I say things like this, that this is not to suggest that everything in the United States goes well. Okay? But it is hard for me to listen to the discussions about how you can fix the inpatient acute care system without, at the same time, developing an integrated, robust ambulatory network of care. You cannot do one without the other. You can't fix the hospital system by being hospital-centric. It can't be done. If you want to reduce the wait list, or you want to reduce the trolley problem that people have, just like if I want to reduce the similar things in the United States, you can only do it by doing a couple of things. You've got to remove about 30 to 40% of the stuff that's done in the hospital and move it out. About 40% of stuff that is done in a hospital today does not need to be done in a hospital. Most surgery doesn't need to be done in a hospital. Cancer is an ambulatory care delivery, imaging. If you want the acute care side to work as well as we all want it to work, then you've got to remove out of the acute care side those things that shouldn't be there. Because eventually, over the next decade, what the acute care hospital system will be, whether we like it or not, but we should plan for it, acute care hospitals will be intensive care units, dealing with the elderly and non-elderly individuals with serious illness and comorbidities. I am currently planning in our system over the next 10 years for the conversion of pretty much all of our hospitals to intensive care units. And we have removed out of our hospitals, increasingly over the years, a lot of the things that were once there, even 5 years ago, that were in the hospital are no longer there. So when I listen to debates about I can look at the hospital acute care system in silo, can't be done. You'll just spin the wheel, but you won't make any fundamental change. So it's creating the whole cadre of ambulatory services on the outside, everything from ambulatory surgical centers, rehab centers, oncology centers, imaging centers, and home care, huge going forward. You're able to do in the home today things that are now done in a hospital can be done at home. In the future, with all the modern technologies that are being evolved, you'll be able to do a lot more in the home that now you would only consider you can only do in the hospital. So the hospital mentality has to be changed. In fact, if your system is working right, and if my system is working right, hospitals will be the smallest part of it. not the biggest part. And we won't be discussing hospitals the way they're currently discussed. So let me end by making a suggestion. Because I'm conscious of time. Let me make a suggestion. What if, and I evolved from the idea of the hospital groupings and the trusts. What if we created, taking the same regions that the hospital groupings are designed to serve, that you created not a local hospital grouping, but you created a local integrated delivery network. That under that network locally, and I think, by the way, from what I understand, in the region here, in the Limerick region, you probably have a better opportunity to do this than others because I believe relationships work pretty well, etc. here. And that network, that delivery network, has single leadership. But inside it is hospitals, ambulatory, home, long-term, transportation, the whole constellation of services that you need. Because it's like a bowl of Jell-O. You push it one place, it pops up another place. All have to work together in an integrated way because you can't fix one piece and then expect somebody else at another time under different auspice to fix the other piece. It doesn't work. If I'm running a hospital and I want to improve efficiency, going back to what I said before, I would be talking an awful lot about what I got to take out, how I deliver it differently. So there has to be single authority over this local entity. And that region, give it the responsibility for improving the health and well-being of the population in that region. A wonderful definition of population health. So you're responsible for the population. You have to have the authority, though, to make decisions regionally. You have to have the authority to make decisions about staffing, about promotions, about hiring, about discipline, about developing the network and filling the gaps that you now have. You want to have the freedom to develop the relationships that you need. You develop metrics. You say there are metrics on the following. There are metrics on service. There are metrics on quality. There are metrics on safety. And by the way, safety and quality are all part of the same continuum. They're not two separate things at all. They're all part of the same continuum. And you give that local region budget authority. You're spending the money today, right? Take that amount of money and you make that available for that regional delivery system. And if central government sets some rules, it sets some metrics, and then it gets out of the way. And by the way, what you will do is you will allow for lots of experimentation. You do the same. You do something like this in a number of your hospital group regions, the ones that you're currently working on. You turn them into something differently, and you create this little competition. And by the way, one other thing that should be considered strongly is how you tie compensation to performance. I don't perform, I'm out. That keeps your feet to the fire. If you were to say to me, we'd like you to come back in 3 years, I say, yeah, I'll be back. I may not have my current job. I got to deliver. These guys got to deliver. Elaine, Brennan, Peter, Tom. And when Tom gets up here, Tom again, he's the chair of medicine for our health system. But he's the chair of medicine on the inpatient, the ambulatory, the home, the whole continuum across for the whole health system. He is not focused only on inpatient. The tradition, even in our system many years ago, was the chair of a department concerned himself or herself only with what went on inside the four walls of the hospital. Fundamental mistake. In the world that we need to go into, if we're worried about improving health, and even only if we're in a world of actually improving the delivery of medical care. Now, some people will say it's not possible to do this. My attitude is, why not? Why not? If you want to create something new, you've got to break the old. And in New York, our organization, we have a reputation for getting out first, for breaking some rules, for making mistakes, for recovering. A year ago, we opened up in New York City, the first of its kind in New York. They did exist in other parts of the U.S. A 24/7 high-tech, comprehensive emergency department without any beds. No beds. Not in a hospital. Unbelievably successful. People said, that's stupid. No, it isn't. It works. It really works. From the time a person comes into that place to get service, from the time they walk into the door to get a service, it's 11 minutes. That's what the customer wants. That's what the customer deserves. It doesn't matter that it might be hard on me to do. That's not their concern. That's my responsibility. Okay? And some people will say this is too big a leap. And I like to quote, as George Eliot basically says, only those who risk going too far can possibly find out how far one can go. So I think both in the US and here, we have a wonderful opportunity if you are the type of person that wants to be a leader, and you're the type of person that loves breaking and bending some rules, trying to be innovative, getting out front, to some extent asking forgiveness, not permission. And one of the best definitions of leadership that I've come across is that leadership is about managing the present, selectively forgetting the past, and creating the future. You know, this is a wonderful facility. It's been referred to as a wonderful place. This is where new ideas should blossom. This is where challenge should blossom. This is where people should stand up and say, we're going to do it differently. If Ireland goes along and only creates a hospital network, you will be spinning your wheels forever if it's not in the context of the totality of what impacts health and well-being. Because by itself, it's doomed to failure. If it's not by itself, and it's integrated with all of the other pieces, as I mentioned, you have a great chance of success. So with that, I'll turn you over to the MC. Thank you so much.